Hello, everyone. Good evening from here in Nigeria. So today is World Sickle Cell Day, just like every June 19th. And we are live on the interactive session, just like we promised. We sincerely apologize for the lateness in starting up the live show because of technology challenges and the rest. We sincerely apologize for that, but we'll go ahead. Since we are live here, we can proceed. So I will be introducing myself quickly and followed by the special guest we have on the show. My name is Nonso Stanley Aneke. I'm the founder of the Olympus Sickle Cell Initiative, and I'm glad to be here with you today. Today we had a very long day. We had the rallies and the rest. Going on, I'll be introducing my special guest who is here with us today, Dr. John Aneke. He's a consultant hematologist with the Nnamdi Azikiwe University Teaching Hospital, Nnewi, Anambra State. And then also he's a sickle cell disorder expert. You're welcome, sir.
Thank you, everyone. I'm so happy to be here.
So we'll be quickly going ahead with some of the overview questions we have so that people can key in and understand. First, we'll be starting with informing and reminding that June 19th, just like today, is the World Sickle Cell Day. And everybody all over the world is remembering the incidence of sickle cell disorder. And we're trying to throw more light on informing everyone on the effects of sickle cell disorder in the whole world. Presently, we have over 8 million people living with sickle cell disorder, and more than half of it is domiciled in Nigeria alone. With even that high number, we have over 150,000 babies born into that number every year. That's why we are doing what we are doing. We've lost friends, we've lost loved ones from the sickle cell disorder. That's why we are pushing and we're passionate about what we do. As we go ahead, we would like to do some little question and answer session with the experts we have in our midst. And we'll be starting quickly with the first question. We'll be asking to know what is the sickle cell disorder. We're assuming that some of our viewers may not understand what it is, but what is the sickle cell disorder? And what are the symptoms?
Okay, thank you very much. Sickle cell disorder is a genetic disorder, meaning that it can be transmitted from parents to their children. That's why it's called genetic. And it's a genetic disorder that leads to the presence of what they call sickle hemoglobin. Remember, hemoglobin is just the pigment within the red cell that carries oxygen. Yes. So for a normal person, the hemoglobin is what they call hemoglobin A. That's the one that carries oxygen very well without any problem. But the S hemoglobin is the one that people with sickle cell disease will have in their red cell. So the red cell of people with sickle cell disease will have the S hemoglobin instead of the A hemoglobin. And that leads to a lot of problems that are associated with this disease. So in a nutshell, sickle cell disease is characterized by the inheritance of the S hemoglobin. The presence of the S hemoglobin confers on the person a lot of symptoms, a lot of complications that are known with the disorder. So in terms of the symptoms, you have what we call the acute symptoms and then the chronic symptoms. The acute symptoms are the one that we typically call the crisis. The crisis, that's the one that comes in acutely, and then the person could come to the emergency room because of it. Then the chronic ones are the ones that take time over the years. It usually involves the organs. So they take time over the years to manifest. Okay, so the symptoms could be acute or chronic, like the chronic are the complications. Now it comes to the coming to the acute, the commonest one is the pain crisis. If you've lived with people with sickle cell disease, or you have a neighbor, a friend, you will be familiar with that. The pains are usually on the lower limbs or the back or the chest, so they tend to have these very severe pains that most times will make them come to the hospital. Okay, so in terms of symptoms, like I mentioned, it could be active presentation, it could be like a long-term chronic pain. And the active presentations are typically, commonly, the pains that they have, what they call vaso-occlusive crisis, or in a layman's language, the bone pain crisis. So that's the commonest presentation of the acute symptoms.
And is it a must that someone must present with such symptoms? Is it possible that someone can have this SCD but may not have the crisis at all over a period of time?
It's possible, because you see, sickle cell disease is a very heterogeneous disorder, meaning that one person may not present exactly the same with another person. There are lots of variables that makes the presentation and the symptom different from one person to the other. You're very correct. There are individuals that may have crisis only once in 3 years, 4 years, 5 years, while some other people may have crisis, and that's this kind of pain almost every other day. Let me give you an example of one reason why some people may not have this kind of frequent crisis. That's what they call baby hemoglobin, hemoglobin F. That's fetal hemoglobin. It's been found that individuals with very high levels of baby hemoglobin may not even have crisis. So such people may go for years without having crisis, while those with very low levels of this baby hemoglobin tends to, go in and out of hospital. Another thing is that, when you say sickle cell disease, is an umbrella name that represents those with the hemoglobin SS, and those with hemoglobin SC, those with hemoglobin S beta tau, those with hemoglobin SD, and all that. So among them, the most common, the ones that tend to have worse symptoms, are the ones with hemoglobin SS. So when someone tells you, oh, I have sickle cell disease, you need to find out which one the person has. Because if the person has something like S beta tau or SC, the person may not have pains. So there are a lot of things to bring into perspective when you want to look at the symptoms and the way sickle cell disease patients present. So you're very correct that people may not have frequent crises, while another person may have very frequent crises, depending on a lot of interplay of a lot of things.
Other factors, yeah, it's true. Okay,
yes.
How can this be managed? How can someone that already has this SCD be managed? What can you do to keep them alive?
Okay, thank you. That's a very important question. Now, because of the fact that, remember I mentioned that the presentation can be acute or long-standing or chronic. So managing them depends on the presentation. If it's an acute presentation, usually it's in emergency room. Okay, so for acute presentation, you have the so-called crisis. Like I mentioned, the commonest one is the bone pain crisis. You also have the type of crisis where the blood level drops, where the blood is pooled within the spleen. So the blood just drops like that. They call that sequestration crisis, where the spleen kind of mops up all the blood in the system, and then the person's blood level suddenly drops. The person could go into shock and die if not treated. You also have the one they call hyperhemolytic crisis, meaning that the red blood cells are broken down at a very fast rate. It also causes the blood level to drop. And then the last one, but not the least, is one they call aplastic crisis. That one happens when the bone marrow, which is the factory of red blood cells, suddenly shuts down. Usually secondary to viral infection. So the bone marrow shuts down and then does not produce any blood cells anymore. So the blood level also drops, and the person could also go into shock and die. So the thing is that in terms of management, acute presentation, you will have to look at the kind of crisis the person has and then tailor your management towards that. Like I mentioned, that the commonest kind of acute presentation is the bone pain crisis. So the mainstay is to try to make them comfortable, try to ameliorate the pain by giving them pain relief. Usually by the time they come to the emergency room, the pain severity might have been very high by then. So you have to use like injectable pain relievers, injectable painkillers to try to knock off the pain. And not only that, you will have to look for what's causing the crisis, because most times crises are triggered by something. It could be infection from malaria. It could be stress, like when somebody stresses himself or herself. It could be from dehydration, like the person has not taken water and is so hot, the person losing water from breathing, from sweating, and a lot of other things. So you need to find out what triggered the crisis, if you can identify it and then treat it. If it's infection, you treat, like malaria. If it's like cough, like respiratory tract infection, you treat. If it's another infection, you treat. And then you try to knock off the pain and do other investigations to make sure that the blood level is okay, the renal function is okay, the other organs are okay, and just make the person comfortable. If the person is dehydrated, you need to give the person fluids to restore the cardiovascular, the circulatory volume. Okay, so that's like, so the acute in a nutshell depends on how they present. All right. So then the chronic, which is like the long-term complications, is mainly organ dysfunction. Almost all the organs in the body can be affected by sickle cell disease. Talk about the heart, talk about the kidneys, talk about the brain, talk about the liver, talk about the spleen, and talk about the bones, you know. So talk about the eyes. So you need to, what they call organ surveillance, where you need to like review the organ function, usually like every year or once in 2 years, where you do organ workup for them with the idea to identify these organ dysfunction if they are there, and then start early treatment.
And then handle it.
So the treatment, sorry?
Yes, you mean doing that like every 2 years so that you can
Yes, or yearly, yes. Exactly. Exactly. In fact, there's what they call comprehensive care of sickle cell disease patients, where you plan their care to make sure that you look for this organ dysfunction. Okay, for each person on the records, you know when the person last had an eye check, so that if there was a problem, then you do it every year. But if there was no problem, you could do it like every 2 years. They'll send ophthalmologists, they check the eyes, check the back of the eyes, the retina, make sure everything is okay. The same thing with the heart. They do echocardiogram for them to make sure that the heart is pumping well. There are no issues with contraction and all that. Yeah, so it's a comprehensive thing where they check all the organs. They check the bone density as well. You need to check the bone density, because if the bone density is low, they could have fractures. Okay,
Yes.
So that's the thing. It's a multifaceted thing where you plan the acute care if they have crisis, and then plan the comprehensive care for the chronic complications, for the long-term complications, just to make sure that if there's anything you identify, you handle it early to make sure it doesn't, develop into something like an organ failure that is may result in mortality.
Just today alone, I received about 3 calls alone in the morning from friends who are healthcare workers, informing me of a patient they have in their different facilities. Just because
Yeah.
they saw what I posted on Facebook, they were asking, is there any special thing we are doing for these people? And is there any other help we want to provide? I just told them, just like you said, handle the presentations as they come in, because just like you handle this person doesn't mean that you handle the same way to the next person. And from another special information you are giving us today is that there should be a routine checkup or runoff on all the organs in the body, even the bone. This is what keeps people alive, and I'm glad that we're getting it from you too. Thank you so much. Now, there is a myth we have. I don't know whether I should call that a myth or not, but people say that you can outgrow the sickle cell disorder, this sickle cell anemia itself, that there's a particular age where if you pass that age, thank God for your life, because you not die again. Is it true?
Oh, I heard a lot about that while growing up, Then back in the days when we were like in primary school, it was a common thing that when they get to like 25, if they cross like 25, they won't die again, the sickle cell will just disappear. But that's not true. When I started reading hematology, I understood that, well, that's way far from the truth. Look, think about it this way. It's a genetic thing, it's in the gene, it can never go unless you remove the genes. That's the only way you'll be able to treat it. So it's not going to just disappear like that with age, the way they made us understand when we were all growing up. So it can go. It lives with someone until the person dies, unless one does a transplant, like to remove the stem cells, or do a gene therapy where they like remove the gene that is defective and put a normal gene, and the person starts living normally. So, but if it's to disappear spontaneously, no, I'm not aware of that.
So talking about the transplant you talked about now, what is the success rate in Nigeria?
Well, we are a little bit unfortunate because we don't have universal health insurance that's like advanced the way it is in other countries. Our health insurance is still coming up. It's still like coming up. Okay, so you find out that a lot of sickle cell disease patients for now may not have access to the health insurance to be able to afford transplants. So the transplant in Nigeria, it's there. There are centers doing it now, thankfully, but it's way beyond the reach of ordinary Nigerians because it's quite capital intensive. We are hoping that by the time
Has it happened in Nigeria yet?
Yes, it has. It's ongoing. The only thing is funds. I think that's the main thing that is reducing the number of people that are accessing is funds. But when you compare this with other countries that have universal health insurance, fund is not a problem because the government actually funds it. The insurance system funds it, so you don't have to pay out of pocket. But here, because we're still like developing, it's still a problem because people have to pay out of pocket, and it's not easy. It's not affordable to most common people. So that's why only very few people still end up accessing this type of care for now. But the technology is in Nigeria. The know-how, the capabilities in Nigeria.
Okay, thank you. Then the last question from me would be this way. We have some couples already existing in Nigeria. Probably they didn't know about the sickle cell disorder and the issues with genotype, and now they're already married. Some of them ask me questions like, if they have a baby, okay, let me say the wife is pregnant, is there a way of finding out the genotype of the unborn baby when it's still a fetus in the uterus, so that they will be able to prepare themselves and know what else to do instead of giving birth, okay, every time and then of a baby with the SS genotype? Is it possible?
Yes, it is. It's possible to do what they call prenatal screening, where they take material from the developing baby and then actually screen it to know what the hemoglobin type of the baby is. So you can
At what,
actually know,
at what
well, from
moment?
like 12 weeks, like 3 months,
Wow.
some even as early as 8 weeks. Okay, so 8 weeks, 12 weeks, 16 weeks, depending on the type you're doing. So you can actually take some genetic material from the developing baby and then test it in the lab to know what the hemoglobin type of the baby is. Yeah,
Is
it's the
this
technology
is this procedure accessible in any facility presently in Nigeria?
to the best of my knowledge, no. Even if it's available, it might still be restricted to some very few centers. It's not like universal. For instance, in my hospital is a tertiary healthcare center. We don't have it. And I'm very sure also that in most tertiary hospitals within the region, we don't have it. But I suspect that some private hospitals, maybe in Abuja and Lagos, may have it. I'm not sure. But in most government-owned tertiary hospitals, we don't have this technology now.
Okay. Thank you very much. And while we look out for other questions that may come in from the floor, I will first again thank you for this time out. We'll be listening out and looking out for other questions coming in from the floor if there are any. Then while we wait on that, I would want to use this time to share some idea to the listeners and other members of the public that tuned in to share on what the Olive Sickle Cell Initiative is doing so far, the strategies and what we are doing so far, and how we feel and how we believe that it can work. First, the Olive Sickle Cell Initiative has been existing since 2016.
Okay,
and has
thank you
been
very
doing
much.
a lot. Yes, has been doing a lot, and we believe that we can reduce the incidence of sickle cell disorder in Nigeria at least to some reasonable extent by the year 2030. That's why we're doing what we are doing, and we are doing that under 4 major objectives. First is education and awareness. Education and awareness is very important to us. We provide this education and awareness through the social media campaigns we do, through such lectures like what we are doing now. We provide that through school reach out campaigns. We visit schools, talk to the senior secondary students, making sure that they understand what this sickle cell disorder means and the effect of not knowing their genotype now, what it will do. So we provide this education, we correct myths, some myths, just like you corrected today, that there's no particular age you can say you've outgrown the SCD. No, these are part of the things we try to do to educate the public on what is applicable and what is accessible. Then secondly, we provide advocacy. Why do we say advocacy? Presently, many of these persons have been sidelined. Many of them face victimizations. In fact, before now, all of us already are aware that in the olden days, I'm sure it's still practiced some other places, they are called abiku or obanje. Just like you give birth to a baby and they will die, they'll come back again. Or over time, people started knowing these are effects of discordant couples of AS and AS getting married. We try to speak up for these persons by doing what? We provide advocacy visits to some stakeholders. By stakeholders, we mean some persons in the society whose decisions or influence can affect or influence the SCD. Example, the government, through the Commissioner for Health, through the NHIS and health insurance schemes and agencies existing in some other states. We try to pay courtesy visits, advocacy visits to them so that they can float health insurance schemes, at least for these type of persons. Just like you pointed out, a major factor which affects the success rate of the bone marrow transplants being funding. If we have at least, even if it's not for the bone marrow transplant, but at least for the basic health care coverage for these persons, at least we are sure that mortality rate will be reduced. We also pay advocacy visits to some other stakeholders like the churches and the mosques. These church leaders and religious leaders, we go to them because they are the ones that try to join couples into matrimony. And we believe that their decisions by asking you to check your genotype would go a long way to read or preventing discordant couples from going ahead, at least some of them or most of them. This is part of the things we do, advocacy, speaking up for them. And so far from the visits we've placed to some of them, it has worked. And we also pay advocacy visits to some other traditional rulers. Some persons may not be religious in nature, maybe going to churches or the mosques, but they still get married in their community. Those community leaders have a part to play. We pay advocacy visits to them so that they will also help us in sensitizing their communities and letting them know that in as much as we are trying to join you up in holy matrimony or any marriage at all, they need to know your genotype. The third objective of the Olive Sickle Cell Initiative is philanthropy. The last time in 2018, when we went to run an awareness rally, we discovered most of them there never wanted to check their genotype, partly because they feel that I don't have money, 1,500 or 1,000 naira to go and check that. part of the things Only Sickle Cell Initiative does is going around providing free genotype screening as much as possible to persons that want to check their genotype or even confirm their genotype. If not for anything, if you are AA, we've seen situations where people will say they have AA and now they are AS. There are many other factors that can actually affect that from the laboratories and other places. But if not for anything, check and confirm your genotype. And we try to provide this thing free of charge, just trying to make sure that we mediate that part of cost. It's part of the things we do. And every other services we provide, we try to make as much as possible to make sure it is free and accessible to the community, especially underserved areas in the community. Then lastly, the fourth objective we have is psychological support. Why? We've discovered that some of the persons living with sickle cell disorder, some of them usually feel they have psychological breakdown at sometimes. They sometimes ask themselves question, why am I in this world and I'm suffering this and that. Some of them even try to commit suicide. We have some psychological and counselors amongst us who try to talk to these people, try to engage them and encourage them to know that they can still have their life and live it fully. We try to also talk to even some of the parents. Some of them feel so bad that they feel guilty that they were the ones that beget their child and put them in that situation. And some of the parents probably they were ignorant. Some of them might have been given wrong results at some point. But the fact is that they now have a sickle cell warrior amongst them. We try to still encourage them and give them life. There have been some other activities we've carried out. Activities like the I Care Scholarship Project. Last year, we were able to enroll at least one sickle cell warrior in his primary school from primary 1 to primary 6. We have agreed to pay the school fees. We hope to still carry that out also by this August to enroll some more persons amongst that. But that was in our 40th anniversary last year in 2020. This year, we want to step it up. Why are we doing that? Presently, we know that some parents have not been confident enough to continue paying school fees for their kids or investing in them because they feel like after all they may die soon. We don't believe in that. We believe that notwithstanding that they are sickle cell warriors, it wasn't their fault. And as such, they shouldn't be made to pay hugely for this. Make them have access to everything they need. It is their right. Right to education is still possible. That's why we try to play our role by giving them that access and helping them, especially indigent ones. Managing these sickle cell warriors is not really easy. We know how much it costs to even go to the hospital, transfuse blood, take the medication, and many other issues that come up in to the sickle cell warriors. We believe that we can create a pain-free society, and that is what we do here today. The pain comes in different aspects. Pain, physical pain from the crises that come up to them, pain, emotional pain that some of them, you see someone you love, you want to get married, and you've been pushed to dissolve that and cancel that marriage because you are AS and it's AS. That's emotional pain. We've also seen psychological pain. Some of them don't even think about their future. They believe that they may not be alive for the next 2 years, so they don't try to think about their future. There are several pains already in the society caused by the SCD, and we believe that we can still make this happen and create a pain-free society. The only way we can do that is what we preach. Know your genotype now. Find out your genotype so that you don't join up in bringing in other innocent kids into the world to suffer from this pain brought about by the SCD. This is what we preach on a day like this. Thank you. I don't know if we have some questions that come up. Yeah, let's see one of the questions and know what we can do. Okay. So someone is asking, Chief, I guess you're still online. Someone is asking, please, sir, how about the myth that one can outgrow sickle cell disorder? We've already attended to it, but the person is requesting for more clarification on how possible, or is it true or false, about outgrowing sickle cell disorder at a particular age. Okay. Yes, trying to, while we wait for Chief to come up again, I guess the network is delaying that. We've already been counseled and advised that it is a myth, it is not true that you can outgrow sickle cell disorder. All we do is just to take care of the person, handle the issues that come up as they come up. If it is pain, handle pain. If it is anemia, transfuse blood. If it is maybe organ issues, try to handle them. And if, in fact, he even provided a guide that at least annually go for a routine overview of across every of the organs in the body, even the bones, so that you can at least handle any issue trying to come up from any of them. So it's actually a myth. Though, and notwithstanding that, we are sure that we read up some time ago about a 92-year-old sickle cell warrior somewhere in Lagos still alive. So it is still possible that you can live for how many years as much as possible of your life, especially if you take care of your health and take care of yourself. I guess I answered that question. Let's look at any other question if there is any. Okay, there is no question presently. And we want to use this opportunity once again to thank everyone that tuned in to this live broadcast interactive session. Feel free to still send us questions as much as possible. Send it through our inbox, send it direct to any of us, and we will be sure to answer that when the time comes up. The reason we do this is to reduce the incidence of sickle cell disorder in Nigeria. And we believe that we can do that if we partner and work together. How can we do that? Know your genotype today. We have had many stories of people, how much money they've spent in managing a child that has this SS genotype. It is not really easy. But we know that joining up now, we can at least reduce that number of persons living with sickle cell disorder in Nigeria, and we can do that. I will tell you a story of one of my friends, anonymously, I'll put it that way, who was about getting married. We were discussing about genotype. He said, okay, is it necessary? When he checked, he was AS, or he is AS, the same as the wife. By then, he had already carried out the traditional marriage. He told me, I don't think I can bear to live without this lady. I tried to counsel him and encouraged him. He refused. He went on with the marriage. It wasn't really easy for me trying to push him to come off it, but he went ahead to get married to that. They gave birth to a baby. Incidentally, the baby was AS, and we thank God about it. But one important thing when we started discussing again was, he was telling me, after all, you told us that it's possible that you may not still give birth to an SS baby. Yes, of course, it's true. But it is still possible that you can give birth to all 10 kids of SS. And at the same time, it's still possible to still give birth to all 10 kids of AA. But it's probability. Why take such a risk? I even try to encourage such people and argue with them in this way. I ask them, what if you try to get married to someone and you discovered a particular health condition that was hidden from you? Would you go ahead? And the person said, no, I may not go ahead. Then why would you want to go ahead with someone you know that is AS and you're also AS? Is it because the SCD will not affect you directly, but to your kids? That's selfishness. Think about these unborn babies. If they had their way, they would want to remain healthy. If you look at them, how you manage them, how they go to the hospital, piercing their bodies with injections, managing pain, they develop ulcer, they have organ damage, some of them go into having stroke, kidney failure, and start using dialysis. All these things are pains that could have been prevented if we know your genotype today. We preach that today. Know your genotype. On this day, World Sickle Cell Day. Thank you to everyone that tuned in to this live broadcast and interactive session. Thank you to every member of the Olive Sickle Cell Initiative. You guys are the most important persons I have now. You're the most valuable persons we have. Thank you for making the World Sickle Cell Day, June 19th, a success. And also to my team members like Henry and Yokwa at the back end trying to make this happen, and other members of the leadership of the OSCI. We thank you so much for what you do. Keep preaching this. Know your genotype today. Thank you very much. I remain your friend, Nonso Stanley Aneke. Thank you.